A very good evening to everyone. Wish you all a very happy new year. Brainchild Trust presents its first talk for this year, and we have Dr. Namrata Upadhyaya with us today with a very interesting topic, understanding adolescence in children with special needs. Dr. Namrata is a pediatric endocrinologist. She has done her MBBS from MS Ramaya Medical College and her pediatrics from Goa Medical Institute. She completed her pediatric endocrinology from Indira Gandhi Institute for Child Health. She's associated with ASSA Hospital. So, ma'am, a very, very warm welcome to you and thank you for accepting our invitation. I warmly welcome you to take over the session.
Thank you. Thank you so much, Apurva, for such a lovely introduction. So at the outset, I would like to thank Brainchild Trust, Dr. Gauri, for giving me an opportunity to talk about this topic. So I have tried to keep it simple and I hope it would benefit. And please let me know if you have questions and I'll definitely try to answer them. If anything that requires further reading or getting back to you, I will get back to you via email. So I'll start sharing my slides. So in today's topic, I would like to, my intention is to cover the following objectives to describe what is normal adolescence, changes of normal puberty, preparing a child for puberty, which I feel is the most challenging part, and we will be talking about it in a little bit of detail. Abnormalities in puberty, bone health, which is a very important aspect in puberty, especially when in children with special needs such as disability, and management of these abnormalities, and coping with these changes and what to look out for. So what is adolescence? So adolescence is a transitional phase which allows a child to develop into a full-grown adult. So typically, we describe adolescence from the age of 10 to 19 years. So it includes a series of complex changes, including physical, emotional, cognitive, as well as social development. An integral part of adolescence is maturation of the sexual organs and sexual functions in a staged manner throughout the period of adolescence. There is a lot of emotional, cognitive, and social development, and there is the acquiring of independence and autonomy. So the physical changes of all this is what constitutes puberty, and we as endocrinologists, we mainly deal with these physical changes and what problems they can arise and how to address them. Especially in children with special needs, they may have different types of pubertal abnormalities depending on the underlying type of the special needs that they have. So they will have to be addressed accordingly. So intellectual disability, as we all know, is a very broad spectrum of conditions where there can be a lot of issues involving not only physical development, but also cognitive development, daily life skills. Communication is going to be a very important barrier in many conditions such as autism and autism spectrum disorders, which can interfere, which can become worse during the times of puberty. And also other children who have epilepsies or who have cerebral palsy, they may have varying degrees of physical as well as intellectual disabilities. And all this, I hope the talk includes, I hope to benefit all those who are dealing with these kind of children. And depending upon the degree of limitations that they have, we may have to use different techniques to address them. So what is puberty? So Puberty is mainly the physical changes that involve the normal and natural process where a girl or boy becomes sexually mature. So what we need to remember is puberty can progress normally irrespective of the underlying physical or intellectual disability that the child may have. So it is mainly driven by hormones. So it many a times it can this is what can cause the caregivers to be ill prepared for this seemingly natural event, which can lead to a lot of stress not only for the child going through puberty but also the caregivers. So this is also in terms of the physical and emotional changes that take place. So typically, girls go through puberty between the ages of 8 to 13 years, although 1 or 2 years on both the extremes can be seen. And boys typically begin puberty by 9 years, between the ages of 9 to 14 years of age. So briefly talking about the um, hormonal pathway. So basically, puberty is activated. Puberty begins in the brain. So it is the hypothalamus-pituitary axis, which is the first part of the first step in the onset of puberty that gets activated. So there is GnRH, which is the gonadotropin releasing hormone, which is released from the hypothalamus, and it acts on the pituitary gland, which then produces hormones called gonadotropins. So basically, gonadotropins are these hormones LH and FSH. So LH and FSH are there in both boys as well as girls, and they act on the respective gonads. So in boys, they act mainly on the testicles or the testis, and in girls, they act on the ovaries. So the end result of that is the male gonads or testis produce the hormone testosterone, which is what brings about all the physical changes that transform a young boy into a young man. Similarly, the gonadotropins act on the ovaries, which then produce estrogen, and estrogen is the one which brings about the female physical characteristics, which ultimately help in transformation from a young girl to a woman. So apart from this, there is another parallel axis that is activated. This is called the hypothalamo-adrenal axis. So where there is a hormone called ACTH, which is produced from the pituitary, which acts on the adrenal glands in both boys as well as girls, and brings about production of adrenal androgens. So even though these are androgens are basically hormones which produce male-like characteristics. These are also produced in girls, and these are the ones which bring about a phenomena called adrenarche, where there is, onset, which brings about onset of underarm hair and pubic hair. So this, although is not really caused by puberty, it happens very closely in tandem with puberty. So both these changes, both these axes together bring about all the physical changes of puberty. So how does normally puberty progress? So let's begin. How does puberty start in girls? So in girls, the breast development, which we call as telarche, is the first sign of puberty. So this usually begins at around 8 years of age, but any time after 8 years of age is normal. So it begins as a small button-like structure beneath the nipples. So that is the first stage of puberty. And this happens because of the action of the hormone estrogen in girls. So this is closely followed by adrenarche, which I mentioned, although is not due to puberty, but it happens along with puberty. So the activation or maturation of the adrenal glands is what brings about the growth of the underarm and pubic hair. It brings about the changes such as increased oiliness of skin, increased predisposition to acne, and the typical body odor or the adult body odor that is seen with progression of puberty is brought about by adrenal hormones. So there is progressive gain of weight as well as increased fat deposition and the fat distribution in a feminine pattern. So there is the most important event is called the pubertal growth spurt, where most of the adult height is gained during this growth spurt. This is under the action of not only the estrogen, but also the growth hormone, which is a very important hormone for growth, is the production also increases during the time of puberty. And these series of steps culminate in what we call menarche, that is the onset of menstrual period, which completes the sexual maturation in girls. Basically, it makes them ready to to be able to reproduce and to be able to conceive and be able to deliver a child, is what the ultimate goal of pubertal progression in girls is. So menstruation typically happens about 2 to 3 years after the onset of thelarche. So menstruation is the last step of progression of puberty in girls. So as I already mentioned, most of these changes are brought about by the hormone estradiol or estrogen, and the adrenarche is brought about by a hormone called DHARS, which is produced by the adrenal gland. So in general, puberty occurs earlier and progresses slightly faster in girls than in boys. So most of the time we may encounter that. Even literally, we say that girls mature faster than girls, but it's mainly because of these changes. So as the pubertal changes progress, even the emotional maturity, the cognitive maturity also happens quite faster in girls as compared to boys going through puberty. So coming to boys, so what is the first sign of puberty in boys? So in boys, the increase in the testicular volume is or the testicular size is the first sign of puberty. So then there is progressive growth of the genitalia. That is, as the testis enlarge, there is also enlargement of the scrotum, which nests the testis. There is also increase in the length of the penis. There is also increase in girth of the penis. And as the puberty progresses, the penis will be capable of making erections. So just like girls, adrenarche happens in boys also along with the onset of puberty, where there is growth of underarm, pubic hair, oily skin, and the development of body odor. So boys also go through a growth spurt, but this growth spurt typically happens a little later than in girls. In girls, growth spurt typically happens just before menstruation begins. So you might see that the girl is suddenly growing very tall, and that means that her periods are around the corner. So whereas in boys, it happens slightly later, in the later stages of the puberty. So that gives them a longer time for growth before the growth spurt. And that explains why the average men are taller than the average women. It's mainly because of the delayed growth spurt in the boys, which gives them some more time to grow before the bones start closing up. So towards the end of the pubertal maturation in boys, so they will be able to produce sperms and in the ejaculate, and they will also be fully capable of reproductive functions. So most of these changes is brought about by increasing amounts of the hormone testosterone, which is the male hormone. So it not only brings about changes in the genitalia and all that, but it also is responsible for the muscle mass, for the maturation, for the growth of the cartilages, which brings about a phenomena of voice breaking in boys. And it is also responsible for all the masculine characteristics like facial hair, and also the cognitive effects of testosterone, which typically gives rise to the male kind of behavior, the aggression and the attitudes, and everything is brought about by the male hormone testosterone. So ultimately, testosterone is also converted to the hormone estradiol, which brings about epiphyseal closure. So epiphyses are basically the growth, epiphyses and the bones are the part of the bones in between the growth plate where growth tends to occur, where growth occurs. So as long as these gaps are open, growth can still occur. But towards the end of the growth spurt, So estrogen causes fusion or closure of these growth plates, so which ultimately stops any further growth, and it will lead to the final adult height that the child can achieve. So puberty is typically staged in what we use as Tanner stage of puberty. So basically, Tanner stage is there for females as well as males. So Tanner stage 1 is pre-pubertal, where there's no breast development, underarm or axillary hair in girls, and pre-pubertal genitalia in boys. So Tanner stage 2 is, just breast but felt beneath the areola. So if you're examining a girl, you might just feel a small rubbery structure beneath the nipple and not extending anything beyond, no breast mound or anything. That is Tanner stage 2. Whereas in boys, it is a testicular volume of 4 ml. So a testicular volume of 4 ml is taken as the cutoff for puberty in boys. So that is what we use to classify whether the child is pre-pubertal or pubertal. Subsequently, there is progressive increase in the breast size, the breast tissue which is felt beyond the areola or the nipples is called stage 3. And stage 3 onwards, there is also the typical characterization of the shape of the breast, and finally the adult breast with the adult contour of the fat tissue. So in males also, there is progressive enlargement of the testis, there is progressive growth of the penis, which gives rise finally to the adult picture. And there is also, with each stage of puberty, the pubic hair and the underarm hair become more and more coarse. They increase in thickness, they are more curly, and their distribution also increases, such that they usually are distributed in a triangular pattern, a full triangular pattern, and sometimes it even extends into the inner thighs. So that usually indicates a very mature stage of puberty. So this was about the physical changes that we encounter in puberty. So going on to the question, is puberty a good sign or a good thing for a child with disability or special needs? So what do we have to say about this? So puberty is associated, we should remember that puberty is a normal physiological process that happens in everybody. So the main advantages are that it is associated with increase in linear growth, and finally he or she will be able to attain their adult height potential during puberty. So since there is a lot of hormonal influence, there is increased deposition of calcium and other minerals, and the bone strength is going to increase under the influence of these pubertal hormones. So this is the time to build stronger bones. And the third thing is, pubertal hormones by themselves, they not only have physical effects, but they also improve, behavior. They also bring about emotional maturity and family interactions in certain situations. This might be at an advantage for some children with special needs or children with disability, because this phase brings about some amount of cognitive maturity or advancement which was not there previously, depending on the underlying problem that they have. So these are the advantages of having puberty. So many people do feel that onset of puberty is actually made the child a little better. And it's also, although it may not be very scientific, but it is also a sense of emotional relief for many patients when their children enter puberty, as they feel that, okay, finally, especially parents with special needs, and because they feel that finally something is happening right. And puberty is not just a physical phenomena, it has a very big social and cultural implications, especially in a society like India, where it is considered a big thing, and onset or maturation of sexual function is considered a very big achievement, or if that is normal, then it releases a lot. It reduces or relieves the parents, especially with a lot of pressure. So it has all these implications. However, it can also be a difficult phase in certain groups of people with special needs, especially children who have problems with communication, children who have autism or other learning disabilities. So it can be associated with difficulty in forming and maintaining social relationships, which is actually a time where children undergoing normal children without, I mean, children without special needs going through puberty, they use that time, or that is the time where they form and build relationships. So this can lead to conflicts among the peers, lack of acceptance, and predispose the child for ignoring, bullying. This can unmask a whole lot of psychological and psychiatric issues which may affect the child's behavior. And it's also a change which all children may not be willing to cope with. So the coping with the changes themselves, coping with the demands of increased needs such as hygiene, especially during menstruation, can also become a source of stress for the child, as not to mention the caregivers, where the child becomes increasingly more dependent on the caregivers to handle situations such as periods or any other emotional or social conflicts that they may encounter during the phase of puberty. So it is a mixed bag. So there are advantages that it is a normal phenomenon, so there are definitely advantages, but it can also unmask a whole load of challenges, so which will have to be addressed, and we will talk more about it subsequently. So it can be a stressful situation for both the child as well as the family, as has already mentioned, especially in girls. So because the onset of periods is scary for many parents even before the child enters puberty, and it can lead to a lot of anxiety even thinking about the fact that the child may enter puberty at some time. So questions such as how will my child cope, how will my child manage while being dependent on others, especially if the parents are not around, or they may start worrying about what if the child grows older and she gets married, or she has to go out somewhere, how is she able to manage? And a very important aspect includes concern regarding maturation of sexuality, and whether their child will be taken advantage of, and whether the child will be more vulnerable for abuse. And also the emotional thing is like he or she no longer is a child anymore, and they're going to become an adult, and there is some sort of anxiety associated with that feeling also. So most of the time there is a lot of anxiety around what happens, what might happen if the child develops her periods and other stuff like that. So it again depends upon the level of intellectual disability or intellectual function of the child. So there might be children with severe disability who are bedridden, and there might be others who have very variable levels of cognitive maturity, variable levels of function and communication and all that. So sometimes there may be children with a lot of gap in terms of their emotional maturity, like a 13-year-old girl might actually have the emotional maturity of only a 6 or 7-year-old, and parents might not really be thinking that even though she's a 7-year-old, her physical changes might be that of a 14-year-old. So it might not strike them, and they may be ill prepared for the situation, and so that can lead to a lot of conflicts. So it's important to be prepared. So that is the main that is the key underlying tone that is set for this. It's anticipating, knowing that this is a very predictable thing, whether in boys or girls, that puberty is going to happen, whether we want it or not, whether a child has limitations or not. It is going to happen naturally like any other child. So we might as well be prepared for that, and equip ourselves and equip the child also with the knowledge and skills needed to the degree of their level of understanding, so that they can cope better. So even though it causes a lot of anxiety for parents, it's actually most of the there are many studies who have assessed parents, who have assessed caregivers, interpretation of how they cope through their child entering puberty. And at the end, once the child entered puberty, they realized that it's actually not so scary, or there was actually no need to worry so much. And actually, the child was able to handle it quite better than they expected the child to go through it. So it's better to be equipped and uh, be prepared rather than becoming anxious and having unfounded fears about it. So what they need to remember is most children with special needs enter puberty at the same time as their peers. So it's better to start to look around for these changes around the peripubertal age, that is around 7 years of age in girls and about 8 years of age in boys. So what is recommended is so these topics have to be introduced to these children who are able to understand in a very gradual manner. So some of the topics that can be listed are about how do we go about explaining of the physical changes of puberty, about menstruation, the need for hygiene, the need for taking care of oneself, the concept of public and private spaces, the concept of good touch and bad touch, how to equip them against being against abuse or something, even though people don't want to accept it. It can be statistically children with intellectual disability or any other disability are at a higher risk of being abused. So even though they may not want to accept it, it's always important to kind of guard ourselves and guard the children to the best of their ability, so that they can communicate, they can come and tell if something is not right, so that they don't put themselves into any harmful situations. And children also need to be taught or explained about normal phenomena, normal things such as attraction to the opposite gender. It might cause them to have some feelings which they may not be able to communicate properly, so that should not be misinterpreted by someone else as trying to harass or something. So it's important that they be taught how to respect other people and acknowledge feelings of the opposite gender, but also know when to act and when not to act. So there is a very nice book by Shannon Nichols. I have shared the reference at the end of my presentation. So where they have something called a teaching toolkit for parents, especially to be ready before they start talking about puberty to their children. So I have just taken few snippets from this. So the most important underlying thing is that there has to be a proactive anticipation. So start predicted changes of these predicted changes and start talking about it in advance, especially about menstruation and all that. It can be a challenging time, especially children with different underlying problems may have issues, like children may have sensory issues or other motor issues or behavioral issues. In children with sensory issues, simple things like even getting them to wear a bra, girls, might actually be a very difficult thing to do. And they may not understand the concept of hygiene, the need for hygiene, the need to change pads and the correct way of disposing, and these kind of things. It may be difficult to make them understand. So these issues will have to be noted down and taught to them in a way that they can understand and in a repetitive manner. And one needs to be consistent in providing their advice, like simple things such as the concept of public and private space, that because even though he or she is a child for the parent, so for the outsider it's still your child is going through pubertal changes or physical changes. So there is some social norms that the child is expected to follow. But children who have these different forms of ID may not be able to understand these social cues, and that might put them as well as the caregivers in trouble. So simple instructions being consistent, like clothes should always be changed in the bathroom and or the bedroom and not in any public space. So this needs to be, these kind of things will have to be reinforced to these children so that they can adapt to it, and over a period of time they will be able to follow it, even though they may not exactly understand why they need to do it. So routines and schedules are a very important part, especially in children who do not like change in their routines or schedules. So it's important to talk about it beforehand and get them to accept that this is what we are going to do for the next few days or the next few months, so that they are mentally prepared, especially with relation to cyclical events like menstrual calendar, like menstruation and all that, where having a menstrual calendar helps to anticipate the child's period so that the child can be prepared a few days in advance, and it doesn't, he or she doesn't panic or go through anxious moments the moment they get their cycle. And it's important to keep things simple and avoid complicated reward systems which the child may not be able to comprehend. So repetition, that is, it's not just enough if we say once or twice. It's important to keep repeating what information you want the child to know, and till such time that you can expect the desired behavior in the child. So some of the tools that have been suggested to be used are visual boards using a multi-sensory approach, that is to teach to multiple senses, because they, depending on the underlying cause, they may have difficulty in following complex instructions. They may be having difficulty in understanding something which they cannot comprehend. So simple things such as using an activity schedule, using a picture board, using something, if you want to teach them about private parts, for example, just taking out a picture of the private part and laminating it, and you want to teach them about hygiene, then just teach them about the tasks that they will carry out in personal hygiene by showing the laminated picture. So these kind of visual boards and visual flowcharts is more effective in certain types of intellectual disability. So sometimes we may have to use the child's own strengths. So, I mean, over a period of time, from birth till the child enters puberty, the caregivers as well as the therapists, everybody involved might have tried different techniques to actually get these children to learn things. So try what has worked before, try whatever technique has worked before for this child, and to teach a new skill or a new subject, and use the same thing to introduce this concept of puberty as well, is one of the ways to get them to prepare for it. And if the child has a favorite character or a favorite cartoon, use them to kind of uh, uh, enact a scenario where you describe the cartoon or the favorite character, doing the things that you would expect your child also to do, and then they are more likely to adhere to that. Role playing and enacting scenarios and asking questions to the child, like what he or she would have done if the child was in the scenario of that particular favorite cartoon or anything like that. So these kind of things, and breaking down complex tasks into smaller tasks is one of the ways that is recommended for effective communication of these children. It's also important to be consistent, calm, supportive and serious when we're trying to teach the child, so that they know that it is a serious thing and they need to do, but at the same time, also the communication channels are open, and the child needs to feel safe and be able to come back and tell you if they are having any difficulty also. So these are some of the tips that I could gather, and those who are interested can definitely go through this book. It's a very interesting book and very nicely explained, including including case scenarios of different types of challenges that they may encounter. So moving on, yeah, so these are some examples of picture boards where you can show the child what is a bad touch, and basically it's very important to equip them against unwarranted abuse or anything. However, less likely the probability is of that. It's always important to be equipped with the right information. So some of the ways to communicate is, again, tell the child what are private things and what are not private things. So talking about private parts or talking about their periods or anything of that sort should be private, and it should be told to the child that, there are these set of people with whom, or of trustworthy adults with whom you can share this information, and not with everybody. So that is one way to get them to understand what is private and not private. And even they should be taught that, no one else other than probably their parents or their doctor should be allowed to touch their private parts without their permission. And if anybody makes them feel, touches their private parts without, which makes them feel uneasy, so they have to learn to say no and then come and tell you immediately. So of course, this could be possible only in children who have some level of verbal communication. So in children who have non-verbal communication, it's a different challenge, and we will talk about it subsequently. So this is another dartboard where, there are concentric circles of trustworthy adults, which, you can teach the child with, who is your family, friends, and what degree of, and they can actually put pictures of these people around these circles to make them understand the boundaries that, each of these circles will provide. It's a very interesting thing that can be used for some children. So this is another example of what is a public space and a private space, and they can be made to explain that this is where you change your clothes, but this is where you study, or this is where you talk to your family, and things like that. So this was about preparation of a child with puberty. It's not only puberty, but it's also a lot of other things, such as protecting themselves, and also to develop social behavior. It's important to, as many times they may not be able to get social cues. So it may be both as it may be harmful both for the child as well as the other person with whom the child is interacting. So the child might also, that even though these children may have intellectual disability to varying extents, it doesn't really mean that they don't have sexual needs, or they don't have they're not capable of liking somebody, or they're not capable of having sexual desires. It is not like that. But although many a times parents or other people would just assume that, okay, the child is disabled, so the child does not have any sexual desires. So this can lead to a lot of social as well as emotional conflicts in the child also. So these kind of visual information can also be used to teach children about these things. So moving on. So although, I always include bone health in puberty in all my talks, because I feel it's a very important aspect. Although it's a non-sexual part of the growth, it's a very important part of physical development. So why it's important is mainly bone. The bone density, the maximum bone density, peak mass begins at the time of puberty, and this is the time where they can invest most, so that later, as mature adults, the children have fit bones and they're less prone for fractures and other disabilities. So as you can see, as the bone growth happens from an infant to an adult, so there is increasing thickness, there is increasing layers of bones that is being formed, and various conditions, especially conditions like cerebral palsy or children with epilepsy and disabilities, because of the lack of muscle or lack of movement, which is a very important stimulus for bone growth, they're prone for osteoporosis, and that can lead to a lot of problems in them subsequently. So bone health is mainly regulated by calcium, by vitamin D, and a whole load of physical activity. How much load we are able to provide to the muscles and the bones is ultimately going to determine how strong they are going to be. So situations where bone health can be compromised is in children who have lack of mobility, who are wheelchair bound or immobile, children who have poor muscle strength due to whatever condition. And also these children are more likely to be more indoors, especially the ones with severe disability, because they are not mobile and they may not be, they're dependent on caregivers to take them around into the sunlight and all that. So that could be another issue. They may be on a lot of medications which affect the action and function of vitamin D, such as anti-steroid medications or anti-seizure medications or anti-epileptics, steroids, which are used in a whole range of epilepsy and other conditions. It can interfere with bone health. And many of these children may also have delayed puberty. So delayed puberty means there is no estrogen or there is no testosterone. So that is going to be a negative factor affecting bone health. And the weak bones ultimately lead to increased risk of fractures. And fractures in an immobile child may be even more difficult to deal with, less mobility, and it can cause more problems. So this is something which needs to be incorporated in any child going through puberty. So depending upon their level of mobility, different types of physical activity can be planned in the background of good nutrition, balanced nutrition, adequate calcium and vitamin D supplementation, a review of medication. So it's important to review with your doctor as to what all medications the child is on, and especially children who are on seizures or steroids, we routinely prescribe them vitamin D as long as they are on those medications, that is to prevent vitamin D deficiency and to prevent fractures. So in severe cases, and it can also lead to a lot of pain. So fractures may not have any other symptoms other than pain, and especially in non-verbal children, they may be going through suffering a lot. So in these kind of situations, there are treatment modalities available to reduce the pain and to kind of make the bones more denser. So it's important to consult your pediatrician or your endocrinologist regarding bone health to address these issues. And a whole load of physical activity, depending upon the level of mobility. Like in bedridden children, even stretches is going to give some movement to the muscles, which can maintain the bone strength. And different adaptive devices such as wheelchairs, adaptive bikes, swimming classes, yoga and dance, a lot of things are available, and we can make use of that. In certain situations, medications have been used to improve the tone, and physiotherapy plays a very important role, and reduction of screen time. So even though these children are, are just sitting somewhere, so it's important to make them more physically active to whatever extent possible. So that is the bottom line of this particular slide. So moving on. So they can also have other associated hormonal problems such as growth hormone deficiency, hypothyroidism, adrenal insufficiency. So many children with severe forms of developmental abnormalities of the brain can also have water and electrolyte abnormalities, and medication-induced endocrinopathies, as we already discussed, like medications like seizures and steroids and things like that. So they may also have to be looked into based on the symptomatology of the child. So moving on. So the other important thing is what abnormalities of puberty can we encounter? So in children with special needs. So one of the most common things that we do see is precocious puberty. Basically, precocious puberty is puberty happening much earlier than the actual age where typically girls or boys develop puberty. So there are different variations of precocious puberty. So true precocious puberty, or which we also call as central precocious puberty, is nothing but the activation. So if you recall the slides where the hormones, I was showing you the activation of the hypothalamus and pituitary glands. So the activation happens earlier than expected. So typically in girls before 8 years of age, and then boys before 9 years of age. So that we call it as precocious puberty. So there is another variant called premature adrenarche. Basically, adrenarche happens because of the activation of the hypothalamo-pituitary adrenal axis and not the ovaries or the testes, which are actually activated. So premature adrenarche is something where they just have onset of pubic or axillary hair, but they do not have true puberty. That means their ovaries or testes are not activated. So there can be many reasons for this. Some of them being, children born very small for gestational age and in certain genetic conditions. But nevertheless, the physical changes that come about in these children can cause a lot of anxiety and in the parents as well as the child. So the true precocious puberty is usually seen in children who have uh, suffered from major brain injuries or malformations. So this happens mainly because puberty is, I mean, even a newborn child is capable of being fully mature. It's only because of the inhibitory signals from the brain which suppress puberty till they enter the appropriate age. But in these situations where major brain malformation, severe birth asphyxia leading to cerebral palsy and all that, these children uh, do not have these inhibitory signals, so that may predispose them for an early puberty. So the other extreme that is encountered is delayed puberty, where there's no breast development beyond even at 13 years in girls, or there's no periods even after 15 years in girls, and lack of pubertal changes after 14 years is in boys is what we call as delayed puberty. So delayed puberty can be primary, that means the girl or boy never begins to show signs of puberty, or it could be secondary. That is, they may have started showing signs of puberty, but it's not progressing. It is either arrested or it's not progressing. So we may see that girls who started menstruating suddenly stop having their periods for months together, and then we may have to evaluate them for any underlying hypogonadism. So this can happen. So primary cause, like delayed puberty, can happen in children who are undernourished, who are immobile, or things like that, where their nutrition is very poor. So that is the systemic cause for delayed puberty. But sometimes it could be medications, especially children who are on antipsychotics for behavior psychiatric issues, and there could be children who have seizures. There is increased prolactin, and this can also cause delayed puberty or secondary amenorrhea, that is lack of periods in girls. So to reiterate, also, since there is deficiency of the hormones testosterone and estradiol in delayed puberty, it can also affect bone health, as we already mentioned. So this can also put the child at risk for fractures. So these are some of the issues that we need to look into in abnormal forms of puberty. So coming to their management, so it again depends upon what abnormal form they have. So precocious puberty, that is onset of uh, uh, pubertal changes in girls, is more in girls or boys. It can both be very challenging and distressing for the child as well as parents. The rapid pace at which the maturity is happening. So usually it may have to be suppressed. It may have to be suppressed with something called a GnRH analog injection, which is given as monthly or 3-monthly injections, and it is suppressed. It suppresses the puberty as long as it is given. So this could be an option in some children, and in others who have already started menstruating, and or in people who are not able to afford or things like that, we may try giving them some hormonal supplements or hormonal injections to suppress the menses, as that is the most distressing part of puberty for them in girls, but it doesn't work in males. So, but however, this does not completely stop the puberty, it only suppresses the menses. So this used to be one of the options which used to be tried many, many years ago, before GnRH analogs were easily available. And other things such as irregular cycles, girls with irregular cycles. See, although irregular cycles may be quite common in any child going through puberty, not only with special needs, the child with special needs may have a particularly difficult time to deal with this because of the change in the consistency or the unpredictability that comes with it. So in those cases, we may have to put them on cyclical low dose estrogen and progesterone every 1 and 3 monthly. and that can ensure that the periods are going to happen at a predicted time when the child can be prepared for it. So, but some of these hormones also come with their own set of side effects, especially weight gain, and over a period of time, prolonged use can lead to weak bones. They may also have a risk for clot formations, and some of these pills, especially estrogen pills, can cause mood and behavior changes, and this can be particularly problematic in children who already have behavioral issues. So intrauterine devices is another option to consider, but for this, the child will have to be significantly older, and not many people in India are actually comfortable of using it. So earlier, which was this is another topic of debate, like so there is a school of thought of people who just say that, or who just think, who just assume that, anyways, the child is not going to have any sexual function, or the child is not going to bear children. So why should she even have periods? So why don't we just remove the uterus? Why don't we just remove the ovaries? So this used to be done a lot of time, and but it's a very it's an issue which has a lot of dilemma. There are a lot of ethical concerns involved. I mean, most of the time it used to be done without any consent being taken. So it is no longer advocated. So it is not recommended, particularly because it's an irreversible procedure. And we're not only talking about menses here. So hysterectomy or removal of the uterus will also lead to eventual ovarian failure. And the ultimate aim why this is considered by parents is like, okay, because of the fear that the child might get abused or the child might get pregnant. So that is the main thing which drives them to these decisions, but it may not really prevent abuse. So that is something which needs to be kept in mind. So in children with delayed puberty, as we already spoke about it, loss of bone strength and all that. So they will have to be, the pubertal induction will have to be done at the appropriate time with estrogen or testosterone. So estrogen can be given as a transdermal skin patch, or we could use the estrogen tablets to induce puberty. Testosterone is typically given as subcutaneous injections. So many a times these children may need ongoing or long-term therapy, or they may just need induction, and then subsequently they may start entering spontaneous puberty and produce their own hormones. And whatever underlying cause, such as nutritional problems or other organ systems are causing the problem for delayed puberty, that particular disease or condition has to be treated. So it's necessary to consult the specialist for the same thing. So moving on, I think we've almost come to the end of the presentation. So yeah, I would like to highlight about some challenges that might be encountered and what to look out for and how to handle them while coping with these changes of puberty. So as I already said, in girls, the irregular cycles, which may be normal in the initial few years for a normal girl, it may cause a lot of distress to girls with, intellectual disability, especially those with autism or other behavior problems. So this unpredictability can cause a lot of problems. So they may benefit from short courses or cyclical courses of hormonal therapy, and so that will give them ample time to prepare and be ready for their periods. Some particular forms of disorders, they can have fear of blood. So especially when it happens for the first time and they have not been prepared for that, and it may cause a long-term emotional damage to them. So it's important that it may have to be taken care of till such time that the child is primed and be ready to accept the phenomena of menstruation. So another thing, dysmenorrhea or heavy bleeding. Dysmenorrhea may also be a common thing in periods for girls, but in some children, the pain itself can be so severe they may not be able to communicate, and that might give rise to behavioral problems. And mood and behavioral changes, such as part of the premenstrual syndrome, can be even more pronounced in children with autism. So that could be another reason why we might have to use oral contraceptive pills. So in children with spasticity, the pain and cramps can worsen because of the increased muscle tone that they already have. So that can lead to irritability, crying, and things like that. So there is a particular group of patients who can have worsening of seizures around the time of menses, especially those who are on multiple anti-epileptics. So there is something called, there is a phenomena where during the course of the menstrual cycle, the fall in the hormones, fall in the female hormones is what brings about the period, the process every month. So at that time, that can decrease the threshold for seizures, and the seizures might worsen during that time. So they may need adjustment of the doses for their anti-epileptic drugs. So in non-verbal children, especially who are not able to communicate, uh, any pain, behavior change, any infections, especially a urinary tract infection or any abnormal discharge from the vagina, should always suspect any abuse. However much we think it may not be possible, because sometimes it can lead to serious consequences, and if not diagnosed and treated early. So that would be one of the other challenges that we may encounter in these children. So in boys, they may have different sets of challenges. So as testosterone brings about linear growth with muscle and weight gain, it may become more and more difficult to handle them, especially they are taller and they're much more heavier, especially in those who are less ambulant, who are dependent or who are bedridden. It may actually make it more difficult for the caregivers. And testosterone is a male hormone, so it can cause more aggression, it can cause more impulsivity, especially in children who already have these. In both boys as well as these girls, girls going through puberty, a lot of normal emotional changes and normal behaviors, which we typically call teenage behavior, might actually superimposed. They may be superimposed with their already existing behavioral problems, and this can make it particularly difficult for the caregivers to handle. So you may have to consult your psychologist or psychiatrist to clearly assess the child as to what is normal for them and what is actually flaring up of their behavioral problems, and so that the therapy, whatever is directed accordingly for that particular child. So that is another thing that needs to be taken care of. And because of lack of communication, as these children, even though they're going through normal emotional changes of a teenager, they may not be able to communicate a lot of things. They may be, there are, it's a roller coaster ride. It's a very confusing time for even a child without any special needs, going through puberty. I'm sure all of us also have gone through that. But on top of that, when they already have issues with communication and comprehension and understanding, it may actually make it worse for them. Even simple things like, they may feel happy at one time and they may feel sad at one time, but they may not be able to explain that, and that can cause a lot of distress. As I already previously mentioned, the tendency for peer forming friendships and relationships, uh, especially with their peer groups, and if the child is going to a normal school, it's more likely that especially with girls, they may isolate the child. They may not. They may start bullying, or they may start making fun of the child, and this can lead to a lot of self-isolation. This can lead to anxiety and depressive symptoms in the child, and they're already struggling with their personal identity because of the teenage years, and these can lead to added problems, and they may also have to be taken care of. So the other thing in boys is about sexual maturity. So as they may have some conditions, even autistic boys, they may have difficulty in getting social cues. So they may show inappropriate sexual behavior in public spaces or the opposite sex, which may be construed as in very unsavory behavior, and the child might have land up in trouble because of that. So all the more reason, I think someone had a question: how do we teach boys about normal pubertal development and all that? Again, being anticipating it, so starting to have the conversation much earlier, and depending upon the level of understanding of your child and the time he takes to understand things. So plan it accordingly and teach him what you want him to first basically understand, and teach him step by step and simple words. And it's very important to use correct words, like if you're talking about body parts, label them. Don't use some funny jargons. Use the name the body parts correctly, describe the functions of them correctly, and proper communication can help avoid many of these situations. And there's definitely it can be done when it is possible. So these are some of the resources which I used for my talk. So this is the book I was talking about, Girls Growing Up on the Autism Spectrum, What Parents and Pre-Teenagers Should Know, Parents and Practitioners Should Know About the Preteen and Teenage Years. So this is even available in Amazon. So those who are interested can actually keep a copy with themselves. So, and there are a lot of other resources given in that particular book also, and a lot of online talks by, psychologists and all who have done a lot of work on this. So there's a lot of information available out there, and useful information which can be used. So with this, I come to the end of my talk. So I hope it was interesting and you all learned something today. And if you have any questions, I'm happy to answer.
So thank you. I think that was quite a comprehensive covering of everything. So anybody has questions can raise their hands, unmute and ask.
There are some questions in the chat box. I think I might just take them. So, is it okay if the 10-year boy's penis size is really small, like 1.5 inch or something? Okay. So, a 10-year-old boy with 1.5 inch, yeah. So, you need to basically consult a doctor, your pediatrician or a pediatric endocrinologist, who can actually examine the child and figure that out for you. So many times, usually there is a micropenis. Children are born with a small penis, and that might indicate some underlying hormonal problem. But many a times it may just be that there is a particular way of checking the penile length. So that only trained people will be able to do. And when we do that and we see the exact length, we'll be able to tell you whether it is normal or not. And it also depends whether your child is in puberty or not in puberty and all that. So it's best to consult your doctor, who will have to examine the child and give you the complete information.
So I think there's one more question here by Swarna. So how to check the bone density? Also, what supplements can we give for bone health?
Okay. So we routinely don't need to check for bone density. But if we suspect that the child has an underlying disorder, or the child has low bone density, okay, with certain histories, okay, one could be fracture, one could be, pain and things like that, we do something called DEXA scan. It's basically a kind of an X-ray which quantifies the bone strength. And the DEXA scan gives us something called as Z scores. So based on the Z scores, we decide whether the child needs treatment for the to improve the bone strength. So there are treatment options that are available, which can be used in certain situations. With regards to supplements, as such, we don't recommend any supplements for bone health. It's mainly vitamin D, because any children who have limited mobility, especially because of whatever reason, they're wheelchair dependent, or they have limited mobility because of underlying muscle and neurological or a muscle problem. So we routinely give them vitamin D, and they may develop vitamin D deficiency also. So when you consult your neurologist also, they routinely check for vitamin D levels and they administer that. But apart from that, there is no other supplements unless calcium supplements may sometimes be given. But apart from that, there is nothing else that you can give for bone health. A very important aspect is to get the child to do whatever physical activity is possible within their limitation, and you could work with your physiotherapist or occupational therapist to get them to do whatever things that they can do, so that will give some amount of mobility, because ultimately that is what is also going to help in gaining bone strength.
So somebody has directly messaged and they're asking. So before going to that, I think more than looking at supplements, we have to look at the wholesome, nutritious diet. So if
Right,
they're
that's
having
very
a lot of
important. Yeah.
dietary or intake issues, then I think nutritionists can help with whatever diet they have, how to get the whole nutrition in. So the naturally is much better, because whatever it is, whatever extra we are taking, it's always a balance between the risk and the benefits. So they can have side effects if overdone as well. So that is something to be
Definitely.
mindful.
Yeah.
And consult whoever it is, even your regular pediatricians can help monitor these things. So that is
Yeah,
important.
rather than getting stuff from over the counter and
Definitely.
landing up with side effects. Yeah, that's a very important point, Dr. Gauri.
Yes. Can we supplement the person with calcium on a regular basis? He's 36 now. Again, the same thing holds good here. I think it has to be
Yeah,
monitored, and if there is a real need, generally calcium supplements is not routinely advised unless certain
yeah,
conditions.
yeah. Unless we are not able to provide enough calcium with the diet, or if the child is really symptomatic only, and then also it will be given only for a very brief period. So it's important to give it under the instructions of your doctor and not on your own.
Uh, Ramya Raman is asking, a parent asked me whether some muscle relaxants can be given during menstruation as a proactive measure in a non-verbal child on the spectrum. Will be grateful for any inputs.
I am not sure about muscle relaxants as such. I don't know if they're trying to, they were trying to recommend an antispasmodic. So basically, menstrual cramps are very common in any girl, and in some children it can be very severe. So antispasmodics are quite safe, and we do prescribe them in children who have like intolerable pain, or they're not able to cope with the menses and all that. So I think muscle relaxants, it's typically in the context of children who have a lot of spasticity and all that. So in those children, maybe if they have problems during menstruation, then it may be best to consult your neurologist and talk to them and take their opinion regarding this.
So it will help to kind of keep a note on what are the changes. So if they're non-verbal, what are the changes you're noticing in the child
Right.
when it happens? So we can preempt and then plan it out accordingly. So if you go with this information, it will be then helpful.
Right. Keep a diary of the
Advice.
change symptoms and things like that. Yeah.
Yeah. But if there's no change in the way the child is verbal or non-verbal, I don't think this has to be given as a routine.
Yeah.
So Madhumita Lal is asking, my son is meddling with penis. It is elongated many times when he plays and peeing little continuously in pants. He's 10.5 years. Could it be pre-adolescent behavior? Not keeping clothes also too sensitive. So I think
Okay.
this child may have a lot of sensory issues also, which has to be addressed. And
Probably.
Dr. Namrata, if you can answer the question.
Yeah, it could be. Yeah, I mean, see, it depends on whether the child has entered puberty or not. It could be exploring their private parts and genitalia is a normal behavior which we see around in this age group. So it may just be normal self exploration, but if it is causing him to do this in public at inappropriate places and causing a lot of distress, then we may have to kind of prime the child, teach him, because I don't know the background, like what underlying condition he has. So depending on what he has, so we'll have to again sit with him and explain to him what is normal changes and what is acceptable behavior and not acceptable behavior. But it may not be an abnormal behavior by itself, because it may just part of normal, pubertal growth, where exploring oneself is a part of that. So that is what I'd like to highlight.
So again, if this child is not keeping the clothes on and too sensitive, you may have to see an occupational therapist or some form of sensory integration. So that will also help improve these things. And again, based on the cognition about making them understand public place, private place, so with the parts like how Dr. Namrata explained. So you can even use visual aids to help these children understand, because not all the time they may be able to understand what you're saying verbally. I think all this together, and if still there's a problem, you have to reach out to the therapist you're working with. If you have anything more specific, you can unmute and ask Ms. Madhumita. Okay, then we'll move on. Yes, go
Yeah,
on.
uh, don't have something very different, but he doesn't want to keep clothes anytime. And most of the times I see him touching his private parts. And nowadays, because I'm trying to train him that you cannot do it in public, so he's trying to get lot of private time. He's going to some corner or in the bathroom, and inside there he's staying bare body, maybe playing with his private parts because he's shutting the door also. So I was having a doubt whether it is related to pre-adolescent, because I don't see any pubic hair growth and all. He is having normal like a child only, but still he's doing this and it is interfering with his learning so much.
So he's too preoccupied, so it is affecting his learning.
Yeah, completely. He
So,
was going to a inclusive school setup, which was a very small place, but even they could not manage this behavior, and he is completely at home right now, only going for therapies.
so maybe setting a time limit also. So this much is okay, come, and then distracting him, because sometimes they need this to regulate themselves. But this symptom itself is not suggesting that it is a precocious puberty,
Yeah.
because it's a
Mm-hmm.
common behavior that can happen any time. So
Mm-hmm.
now I think you're doing a good job by trying to explain the public, private, and space and all that, and he's doing it. Maybe saying 2 minutes you have to come out. So 1 minute up. So let's come out. So something interesting or something he likes doing to engage him in that way, to kind of distract him and let him come out. So don't give too much importance to this particular habit. Say enough, stop, and then letting them kind of uh, because once you give too much importance, stop, don't do it, then it actually do it more.
Mm-hmm. I'll modify this thing. Thank you for the input.
Yes, and if no therapy is happening, kindly find somebody to get the sensory profile done. So the child
Okay.
might be struggling with a bit of help. These things can improve.
Correct.
Okay.
I'll try to get a sensory integration therapy for him.
Yes.
Thank you.
Thank you.
Miss Madhumita, does he have enough physical activity?
I don't
This is
think so,
Apurva.
because
Yeah.
in evening he is doing only cycling for half an hour. I don't think it is sufficient for him. He needs even more because he
Yeah.
has high stamina, and he needs to do more physical activity.
Yes, sometimes that's also a healthy distraction. Also because it gives them a different vocation, a different outlet for their energies, a different interest level. So exploring that physical activities, I think, will also help him.
Help, no? I'll try. Thank you for the input.
Okay.
I need to bring him out of this and being more functional. So want to reduce the time. That's why I wanted to understand.
Yes, so more than the inclusive school, so whatever is what important for him, the way you're looking to kind of get him to be more functional, I think that's the right way. And I'm happy you have come up openly and you're asking these things because I think
I
that is
won't
not
get a
the-
place to openly talk about it actually. This place is rightly the correct place to talk about it because you will not be able to talk normally to anybody just like that about your own child, all these things.
correct.
So,
So good, Ma. Thank you
okay.
for
Thank you.
coming out and asking. I'm
Thank you.
sure a
Thank
lot of other people have this, so it'll help a lot of others as well.
Right.
Yeah. So let's move on to the next question now. So Manoj P, do behavioral problems associated with precocious puberty require pharmacological management along with behavior therapy?
Okay. So the management, I mean, the pharmacological management of for the behavior, I think that is what he's trying to ask, right? So, I mean, there is pharmacological management of precocious puberty, so that will ultimately lead to suppression of puberty. So that is indicated in conditions where, it may be bothersome, although we've not encountered such situations where, worsening of behavior as an indication to stop puberty. But yeah, as I already discussed, it can lead to a lot of changes in behavior because of the normal behavioral changes that are happening during puberty. But I think it should be first evaluated by your specialist, as to what kind of behavior problems is the child is having, what spectrum of problems, and then they can make an assessment, and then based on that, we could take a call. But I wouldn't think that, only for the behavioral problems we wouldn't be suppressing puberty unless there are other, genuine indications to do that. So I think Dr. Gauzi can add
Yes.
more on this. Yeah.
So again, we need to see what kind, how much this is having an impact because pharmacological for extreme behaviors maybe helps the child calm down, but it will not address the underlying issue or what why this is happening. So that needs to, and I think Dr. Namrata has explained what all changes happen. So psychologically also with the hormonal, we already see teens and everybody with the kind of changes happening, the mood swings they can have, the psychological effects it can have, and children with disabilities can have comorbid other psychological condition. So, as Dr. Namrata said, this needs to be evaluated and then appropriate therapy again. What kind of behavior, how much effective it is, and how severe these behaviors are. Based on that, a call will be taken on whether medication is required or not. In certain cases, yes, it can help, but it is not the solution. So, as you rightly said, along with behavior therapy, things have to go side by side. Okay. Anybody else wants to unmute, ask? This is your opportunity. Okay, I think there are questions online that has been asked about how to address the anger and aggression while meltdowns. I think you have to work with the psychologist and
Yeah,
work on the behaviors and what is happening.
correct.
I think Yes.
And the others, yeah, anybody has a question? How to train menstrual hygiene and intellectual disability? I think we already covered that. And is there any brain changes after adolescent in special needs children by Kaustuba? Uh, yeah, I mean, there are, as already mentioned, there is a whole load of cognitive and emotional development that happens, and some part of it is because of the pubertal hormones, and in some forms of ID, it does improve their behavior, especially their cognition and family relations. It does improve, so those changes do happen. Yeah, and at the same time, they can also have more behavioral problems which superimpose with their already existing problems. So, yeah, it's best to work with your psychologist who can screen them appropriately using the tools and then give you a plan. So, Lakshmi Priya, how to address anger and aggression while meltdowns. So, yeah, I think I think you already answered that, right, Dr. Gauri? You have to work with the
Yes.
psychologist. Yeah. So how to make a boy to understand about adolescence, how to teach appropriate behavior, this also we covered. Ritu, how to explain about periods that she has already started, and how to explain about hygiene things when putting hand in a glass of water, how to rectify that behavior. So again, it depends upon what is the underlying problem that the child has, and start from there, like what is her level of understanding. And yeah, as already explained, keep for a hygiene thing, you can actually use a picture board and teach them what are the steps to be followed, and make them do it, and give them examples of a role model who would be able to do it, that will kind of increase their chances of following that. So that could be one of the things, and keep trying, and I think they have to keep trying and not give up. That's very important, and keep repeating it. So how
So
to
again,
deal with,
over here also the visual charts will help. So on the bathroom door, you can put up a visual chart and then they can see and see if any step they have missed out. If they missed out washing their hands before coming out, you can keep alarms. So every 6 hours, the alarm beeps and then they know they have to go change their pads and come. So
yeah,
strategies around helping them learn. And as Dr. Namrata said, again, repetition will help them get used to it and understand.
right. Mm. Antara has a question: how to deal adamancy in pre-teenage children, especially in boys. So again, I think it's some sort of a behavioral issue that needs to be screened. I mean, I think these children need a very formal evaluation by psychologists and therapists, and arrive at a diagnosis before some solution can be offered.
So these
My
changes are common. We find these kind of behaviors even in routine normal children also. So the challenge here would be so you have to even though the other challenges, you have to look at your child at times in the angle as a regular child as well, that this is what they go through, and how you normally treat any other child, you use those strategies first. In spite of that, if it is having a big impact, what is the impact of those behaviors? If there's a struggle in any way, then yes, definitely we have to look into how what to manage, because over here it is not like one shoe fits all. It has to be all around the difficulties or challenges the child has, and how to make that particular child understand. So over here is where you will need professional help. So see them and take guidance, and things will take time. It is not overnight. So continue, follow up, and get the inputs where you're struggling. So I think we've covered all the questions. So, Ms. Apurva, I think we can conclude the session now.
Yes, ma'am. Good evening, everyone. I hope all of you had a very fruitful session. I would like to thank Dr. Namrata for her valuable time, her in-depth understanding of today's topic. I also want to thank Dr. Gauri for moderating the session. And thanks to every participant who joined and made the session a beautiful one, and for all the questions and for all the participation. So thank you very much. Have a very good evening. We have put up our WhatsApp channel on the chat. So if you are wanting to know what further programs we have, you could please subscribe to that. Thank you very much.
Thank you. Thank you very much for giving me the opportunity. In fact, preparing for the session also gave me a lot of insight, and I myself had to actually, I learned a lot of things, which we weren't really familiar with. And, it's a very difficult phase for the parents and the children as well. And, we'd like to try our best to help them out, to go through this difficult phase. So thanks again for this opportunity. I had a great time.
Thank you very
So,
much. And the way you put it
yeah.
out was quite relevant. So that was very
Thank
nice.
you.
So, and Mr. Manoj, I think the other important thing is thyroid issues. That is very commonly seen, especially as a comorbidity, or special need children may develop these things. So over there also, you will have to collaborate with the pediatric endocrinologist. That is also another aspect. So any growth issues, so they're not growing the height or the weight or something is abnormal with their growth. So like precocious puberty, thyroid issues, any
And
metabolic disorders, all these cases you can connect with the pediatric endocrinologist.
even if you're dealing with certain genetic syndromes like Down syndrome or Prader-Willi syndrome, they may have a lot of endocrine abnormalities. So any genetic syndromes, syndromic children with special needs, it's good to refer them to us so that we can evaluate that aspect as well.
Okay. Thank you.
Thank you.
Thank you. Have a good evening. Bye.
We'll conclude this.